Hello, everyone. Welcome to the Maternal Health Learning and Innovation Center's first webinar. We are really honored today to present Dr. Clifton Kenon Jr., who is a dedicated lactation consultant and avid breastfeeding supporter. He's also a registered nurse by training and has worked in many different capacities, including within the Indian Health Service. He also has done a lot of work thinking about and talking about equity and how to make sure that all moms and babies are served equitably and have excellent outcomes. So he is going to talk with us today about coming face to face with my biased self. Thank you again, Clifton. I also want to thank Kimmery Bug and Reaching Our Sisters Everywhere, who is providing leadership and support to this webinar series. Clifton, I'll turn it over to you.
Thank you so much. So again, I am Clifton Kenon. I do want to acknowledge some of the amazing people that are in the room, particularly colleagues that I used to work with clinically in labor and delivery at Duke. I see that Venus and Rachel are both here. We have a lot of shared affinities from having started our clinical careers together. So thank you all for being here, as well as acknowledgements to friends and colleagues at Reaching Our Sisters and Brothers Everywhere. So we will get started, and I will just tell you just a little bit about who I am. So this is me, and this is what I look like on a very good day. Considering we've had shelter in place in Pennsylvania for over a week now, my culture and biases lend themselves to me not showing myself because essential services like barbershops are not open. That being said, I am a lifetime career nurse that has only ever worked in a maternal child. I am a lactation consultant, having been educated there in North Carolina, having went to the greatest HBCU in the world, Winston-Salem State University. No comments in the chat box. And I'm currently a chief diversity officer at one of our United States government agencies. And I have my own lactation practice where I see threshold patients, largely working on issues around lactation supply and continuation. So I am going to jump right in. I do a lot of teaching about unconscious bias, conscious bias, and the intersections. And many of these sessions last for a full day. Today, what we are going to do is going to be an overview. It's going to ground ourselves in some fundamental understanding of terms that perhaps we see floated around. And it's going to help us all understand our personal responsibilities for coming face to face with our biases. It will be important that you have access to the chat box because we are going to attempt to do some first impression activities. And it would be best if you could be ready when we start showing some of the pictures and we can sort of talk through and unpackage, but I'll cue that a little bit later. We are going to be taking questions as we go through. So there is a question and answer chat box that Tamala has so graciously agreed to help triage, and we'll be looking at those to make sure that the conversation is one that's inclusive of everyone. So you don't have to look very far. You can look on Google, Facebook. About every day, there is something that is infiltrating our minds underneath the auspice of bias. Whether this is coming from the Harvard Business Review, whether this is a follow-up from unfortunate situations that happened at national companies like Starbucks, whether it's a corporate training or an organizational training that we've all been led to believe are required because of due diligence, or whether it's the realities of some of the disparities that exist because people are not being listened to. I think all of us have heard the words unconscious bias in a very prevalent way over the last 5 years. And that being said, my first question to each of you is just very simply, Are you biased? When we hear the word bias, it often is not received in a way that's complimentary, but it's often received in a way that's negative. But I want to help us reframe that today and recognizing that while this may have a negative connotation, when we look at this in a more comprehensive way, we will likely realize that these biases, whether they're good or bad, are absolutely necessary for us to survive. So my first question to everyone in here is, are you biased? And I can't see the chat box, so I'm gonna just sort of check in here and there. So I hope everyone responded that they were biased, because if you got out of your sleeping structure last night, perhaps, or this morning, perhaps the first shortcut that you utilized that depended on your unconscious bias was your ability to step foot onto the floor and that it would hold you up. There's no evidence that the floor had been built to hold you up. We all took these things for granted and we do them every day. But if we were to stop every single moment of our life and try to inspect everything that we came in contact with to make sure that it was safe, that it was sound, that it would do this, we might not get a whole lot done, and I would likely still be trying to examine my floor from the bed this morning. This is to say that these biases that we have are absolutely necessary, and having a conversation about coming face to face with our biases is only a realistic conversation if we can center it in that we all have this in common. Nobody is unbiased, despite how much effort they might use to convince you. So in a very simple way, bias is a tendency. It can be a trend. It's often a feeling or opinion, and it usually is one that's preconceived and or unreasoned, okay? Unconscious biases specifically are automatic. And as I said, this, like the example that we used this morning around stepping out of bed onto your floor, these are generally shortcuts that we use to interact with our world. Throughout the next hour, we're going to use a lot of definitions, and I want you to recognize that depending on the school of thought that they come out of, the definitions are not universal. And I don't even think that matters that much in it, that the heartbeat of unconscious bias doesn't have to do with our ability to define and deconstruct something at an academic level, but more about our personal motivations to mitigate them. So I just want to throw that out, recognizing that there are quite a few academics here, and we're not going to spend more time talking about what the actual definition is. When we use these shortcuts very effectively, we as humans tend to dress up nomenclature for things so that they sound a bit better, that they're seasoned with salt, as we say in the South. And we can begin to call our unconscious biases or our conscious biases our intuition. And many of us who work clinically believe that our intuition is very good. I know that working as a labor and delivery nurse, we had a lot of widely shared colloquialisms when people would present to triage. You know, we would say things like, this person has the labor look. In lactation, we often see people and they begin to tell us stories about low supply, and our intuition says that, you know, it's not really low supply and all of these things. Generally, these things may be right. Generally, they may lead us to a understanding that is backed up with evidence that we believe that by using our intuition, we're making sound judgment. And in and of itself, these things are not wrong. And the focus of what we want to talk about today is not in determining if our biases are right or wrong, though it is very clear that some certainly are wrong. What we want to focus on today is the ability to remove the absoluteness of something of being completely the truth. And that's where our intuition can truly get us into trouble. If we believe we have good intuition, and it has always worked for us, then that intuition can be awarded as something that's very good, and it can cause us to harm people. So maybe when you go into a meeting room and you see an open chair, your intuition says, this is an open chair, and therefore, since I've been invited here, I am liberated to sit down. Every chance in my life that I've had to sit in an open chair, I've never gotten in trouble, never been screamed at, and my intuition has always led me to a space of comfort. Except this one time. A couple of years ago, I went to a housewarming in hand with my Amazon gift card and really excited for one of my classmates that had purchased a home. I went in and sat in a chair. The chair proceeded to collapse. It was an antique chair that no one was supposed to sit in. I didn't see a sign that said that, and we had some moments of intense fellowship between me and the homeowner, who accused me of breaking her antique chair. And I said, well, you shouldn't have a chair that people couldn't sit in. And then she asked me, whoever told you that you were allowed to sit anywhere you chose? And that was a prime example of how my intuition became absolute, and something even as simple as awarding myself the power and privilege to sit somewhere without any permission got me into a lot of trouble. Now, granted, we were able to preserve our friendship, but the person certainly was very hurt, and I certainly was very disappointed that I had the inability to check my intuition, and it did result in her antique chair being unusable again. Now, that's a good example. So if you have chairs in your house you don't want people to sit in, recognize most people's bias would allow them to sit, and you might want to put a pillow or some other notification there. We use a lot of different terms for bias. You might have heard of unconscious versus conscious. You might have heard of implicit versus explicit. But let's talk about what these things mean. Explicit are conscious biases, so explicit and conscious can be used interchangeably. These are biases that we directly express. So an example might be, I prefer to work LDRP over just straight LDR. These are things that I'm very conscious of. I'm happy verbalizing them and things like that. These are things that I am aware of. These are things that I am consciously operating in. Examples could be things like, I like whites more than Latinos. I like Chick-fil-A more than McDonald's. I like Raleigh more than Durham, okay? Where the most of our biases are the implicit ones or the unconscious ones, representing essentially all of our biases except a very microscopic number. And these are usually things that are expressed indirectly. These are things that we as individuals are unaware of. However, other people may be able to see them a lot better than we are. These things do operate subconsciously, largely operating out of shortcuts and things of which we put no conscious effort towards. An example might be sitting further away from a Latino than a white individual. Other examples of implicit biases could be things even as simple as how you decide to walk around a store, how you decide who you are going to invite to something, who you may go to coffee with, who you might write a reference for or like their posts on a social media platform. So what happens to activate this pathway of us operationalizing a bias? So when we first come in contact with something, our mind begins to categorize it, and we all do it. So I know we've all heard the self-awarded colloquialisms of, I don't see race, I don't see color, I see all people as the same. We know those things are not grounded in any evidence or science, and we know that people that don't see color and don't see race also wouldn't be able to see things like stoplights and caution signs and things like that. We do categorize things immediately upon when we come into contact with them, whether it's direct contact or whether it's third-party contact, but we use a cognitive categorization. From that, we apply a stereotype, and from that stereotype, one of our types of biases will operationalize. And from those, we can see behaviors that are either inadvertent or those that are overt. This is a very simplified graphic, but there are much more complex graphics that get down much more into the scientific deconstruction. Not really appropriate for this type of session, but if you are interested, in studying some of those things, there are references that I'm happy to point you to. For all intents and purposes, we see something, we decide it belongs in a category, we put a stereotype to it, and then our biases help to write the story. What can be unfortunate about this pathway is that this pathway can continue to operate even despite us having knowledge about the situation of which we've been able to verify as absolutely true. So the first thing that happens when you see someone, after we categorize them, we apply a script, and a script that we apply is a story that we tell to ourselves. Humans are very uncomfortable when we cannot categorize things and build a story of which our mind can comprehend. So a question to you, colleagues, is when you first encounter someone, what is the first assumption that you make about them? Who they are, thank you, Tanisha. Where they come from. Thank you, Venus. Where they live. And in reciprocal, where they don't live. What they do. So these are all things that we do make assumptions about, but Deidre, colleague Epps, I think one of the fundamental assumptions that we make about individuals when we see them is usually related to their gender and race. Can everybody agree that when you look at someone, you immediately categorize their gender? Yeah, I know that I do, and guess what? Usually I am right? So that makes my intuition really good, except when you sit in the chair and it collapses under you because your intuition had no ability to be interrupted. So thank you, Sarah. Sarah says, I try not to, but I do. And these are things that despite our best efforts are largely impossible to be completely mitigated. And this ties to a lot of life experiences. It ties to our culture, our upbringing. It can even tie to respect and trying to identify someone so you would address them in a certain way. So I don't think this is going to go away, but I think we need to understand that from the very initial meeting or interaction with someone, we've created a litany of assumptions, and based on those assumptions, it is going to affect our next steps of interaction. Now, even to arrive at gender and race, that would depend on us using a set of shortcuts, a pathway that lead us to arrive even at what race and gender someone is. What are some of the narratives that you see about someone that lead you to make a determination about their race and gender? And I think we'll just stay here in the chat box. Hair texture. Thank you, Venus. The color of their skin, you know, as Kamara Jones says, through the lens of the light that we're looking. Anatomy, what they are wearing. All of these things, I don't know that anyone is dissecting them individually. These things are happening so quickly and automatically that from the time we see the person, we're already far enough down the pathway that we've made this decision about them. And often our salutation, if we are given the opportunity to interact with them verbally, has already begun to be along the lines of gender specifically. And I appreciate everyone talking about gender, but we also make assumptions about people's sex. And in the world of unconscious bias, though we know better socially, gender and sex unconsciously do operate in an interchangeable way. All right, so on the screen, I want you to look at this picture and I want you to tell me what you see. So somebody said the person is fine. Someone said dreads, a man with locks, a black man, educated, well-dressed, beautiful black man, nice eyes, metrosexual. Okay, so anybody else want to go there and give their first impression, and it should be your first impression. So if your first impression of this person was a Black man with glasses, that's true. But I want you to, when you see the full picture, I want you to tell me what your first impression was. So we have an educated or stylish Black man. All right. So when this was put in a study, this was the sets of comments that came out when people saw this picture and what they saw, right? Now, considering what some of you just said you saw, I would suspect that you were more aligned with what was on the left. And perhaps other people saw what was here. Now, you all did better than most groups that I teach because we generally just ask people for the things that they do see. And people did see dreads. People saw glasses, but most people saw those things and they created a narrative based upon those things. So how come no one said that, you know, I see someone who's visually impaired? Glasses are not usually for visually, are not always for visually impaired. It's a style too. Okay. Now, somebody said, fine, good looking. How do you award this status to people? What was there that led you to that? My previous experiences, this looks like someone that I consider to be fine. His lips, his hair, okay. Someone said this person was educated and stylish. What about this person sort of checked the boxes for you that would award them the status of being educated? Well-groomed, seems organized. Intense look and glasses, okay. The tie thing at his neck. Yeah, I think this is called a ascot. Clean shave with a goatee. Okay, so everyone has looked at this person and created a story about him, whether it's innocent or not. I can tell you that for some people that say this person is fine or good looking, metrosexual, there would be people that would maybe use the same attributes that you awarded those statuses to award other things to. And this is largely due to previous life experiences. And as someone said, this could be an affinity issue. So if you have a college professor who looks like this, or you know someone who looks like this and you thought they were good looking, educated, metrosexual, you could then transfer that status onto them. And this is how we have stereotypes. All right, let's keep going because it gets more fun. Just to continue just a few more terms, because we often, we're living in a society where we want to interchange all terms, and that is something I certainly do not agree or support. Remember bias, what we talked about, it's a tendency, it's an inclination, it's a favorable or unfavorable towards people and things. A stereotype, on the other hand, is a shared set of beliefs. Stereotypes generally operate more on a group level than an individual level. What we have now, which is unfortunate, is we're living in a time where discrimination, racism, sexism, and other stigmas are now all being classified underneath the umbrella of unconscious bias. Whether or not there's some credence to some of the intersections there, it would be my suggestion that we still find the ability to look at these terms in somewhat of a unique way. This is particularly true of racism and discrimination, which is often operating from a conscious pathway and not from an unconscious pathway. Discrimination, they are the manifestations of biases and stereotypes. So this is sort of the outputs. And then of course we have stigma, which I won't read the definition. I think you can all clearly see the intersections there, but you can see why it is important to keep these things in their rightful place. So how does bias affect health, right? So if you have an experience of discrimination, I think the studies are very clear that this can lead to very poor health outcomes. We know that there are good studies that continue to evolve and provide more evidence around the inherent biases that we as individuals have, such as looking at people and saying they are metrosexual and they look good and they're educated. How when we put on our lab coats or our community health bags and badges, how those things don't just disappear. And I don't know about you, but most people are more intrigued by someone that they think is good looking than perhaps someone that is not, and that might affect how we give them care, oftentimes in a way that doesn't have anything to do with our intentions, but it just has to do with this pathway that we're walking down, or our mind is moving on without the ability to interrupt it. So a healthcare disparity. I know I'm preaching to the choir, and why do I have a reference from 2003? One of the reasons is because this was sort of a landmark document that came out of the IOM, but they are racial or ethnic differences in the quality of healthcare due to a lot of different factors. I'm keeping in mind specifically one of those factors being appropriateness of intervention. So when we think about coming face to face with our biased self, and we think about stigma and stereotypes and creating narratives about people that center our comfort of categorization, this is how we essentially have arrived at many of the healthcare disparities that we see, not only within the United States, but across the entire world. So let's talk about communication disparities, right? How many of you have an example of a racial or ethnic disparity that existed in provider-patient communication? Show me what you got on the screen. We just want an example of a disparity that existed between a provider and a patient along the lines of communication. So to save time, I'll give an example, and perhaps a disparity might be people making an assumption about someone's name and their ability to speak English language. Thank you, Ariel. That was the example that I was going to use. And they may do voice inflection. They may know that their ability to speak Spanish or any other language is not where it needs to be, and they would still attempt to try to center their comfort and maybe not call in an interpreter, or they may essentially assume that there's no point at all. This is certainly a reality. Venus, this is another example, often an example that we saw in mother-baby units where people centered their own comfort and asking demographic questions that there was no evidence to any sort of clinical intervention. And from those things, it allowed people to operationalize stereotypes about even stuff as simple as who would or would not even be able to use a breast pump, who would not be able to understand how to use the sitz baths and things like that. So very good. And these are all great examples. So thank you. We know that in the communication disparities, we know that the studies do talk about how underrepresented, marginalized groups, particularly where they are the visual and the demographic minority in healthcare settings, there is evidence that there is misunderstanding and people not feeling as though they are heard. These things are not disputed. We also know that for people that are marginalized economically, that these communication disparities are getting worse. And some of these communication disparities are structural, as we see hospitals and clinics and community health programs and rural areas continue to decline as we see things like public health nursing models and stuff essentially going to nothing in some states and communities. And communication now is a disparity for a lot of structural reasons. And we know that these things certainly affect the poor in a much more rapid and grandiose way. Discrimination in healthcare. These things stem from our bias, our prejudices, our stereotypes, and they create uncertainty in clinical decision making. This is often where individuals use paternalism to make decisions for individuals. An example may be where I believe this person is at high risk of getting pregnant again. They've not been compliant. They're not going to be compliant, recognizing that compliancy is something that's often centered within the privilege of being a healthcare worker. And you may decide that when talking to someone about family planning, that you only talk about long-term options and things that might lend themselves to taking away individual autonomy. This is an example of where we have some evidence around family planning options being disparate and given to certain communities versus others. Some of these things are at the individual provider level. Some of these things are at the structural level. For example, rural healthcare not having all drugs in the formulary, or people that need to utilize mobile units to access family planning, and the ability of providers to provide a variety of things may not always be there. So by default, what happens is, as a provider, your new norm becomes that people that live in this area, these are the appropriate methods for them. People from this demographic background, people with this gravida and para status. Has anyone seen examples of, outside of Rachel, because Rachel and I have been talking about this for years, but has anyone else seen disparity in family planning communication, even with just getting information out about all options to people that they've interacted with? As a lactation consultant, I see this every day. I see that people have never been made aware of the lactational amenorrhea method. And even when they've asked the questions, I hear on a daily, weekly basis that people say, you know, well, it's not going to work for you. You're putting yourself at risk, and things like that, to the point where the communication becomes based in fear. And often this is out of a provider bias that they have, that then gets displaced to the patient. This certainly can affect people that do not have the agency or the resources to get second opinions, to go to more comprehensive facilities, etc. So let's talk about weight. We're going to talk about this a little bit more, but we do that in some really good studies that, you know, in one study, half of all the providers studied thought that obese patients were awkward, unattractive, ugly, and non-compliant. So just imagine if this was your unconscious bias, and unfortunately, in some people's cases, their conscious bias, and you had the influence to train residents and nursing students and other community health workers, and this was the unconscious bias of which other people were able to unveil. Just imagine if you've had that influence across 3 or 4 generations of healthcare workers, how this at scale might affect the entire population. How many of you have been in settings where you have heard inappropriate comments that have been displaced upon the conscience of overweight people by healthcare providers? Anybody been there? I think that this is a much more comprehensive problem than it is an acute problem. And I think this spans back generations. And what we are seeing now that is very concerning is that some of these characteristics of client populations are now being turned around to actually blame people for poor clinical decision-making, and things like maternal mortality in some cases and morbidity are now being placed through a lens of patient blaming or family blaming, when in reality, responsibilities are much more shared, and certain clinical responsibilities are now being removed because of bias towards a lot of different things that are effectively being used to write people an alibi. When we talk about minority populations or underrepresented, marginalized populations, we have to be careful that we do not see the LGBTQ plus community as directly relating only to the majority or the dominant culture. While we know that disparity exists and marginalization exists in this aggregate as a whole, we have really good evidence that within minority or already marginalized communities that the level of marginalization of this population is significantly higher. And we're going to talk about that and we do the first impression. If anybody is still disputing that people of minority status have hesitation for interacting with the healthcare system because of fear of how they're going to be treated, then you are essentially putting up a blinder to what is overwhelming evidence. And unfortunately, it's in a realm of evidence that despite it being overwhelming, there are still people that are disputing it. I tell people sometimes that we're going to have essentially as much evidence around this race disparity with the healthcare system as we do for hand washing. And for whatever reason, it seems the more evidence that is produced, it just seems that the more people that are not convinced. So I'm not fully convinced that fighting this battle of unconscious bias systematically only through evidence is going to work, which is why we're centering the presentation today about individual responsibility for our own biases. If you believe that you're going to be discriminated against, whether it's going to your doctor, your nurse practitioner, your midwife, your WIC clinic, whether it's going to the health department, whether it's even going to a grocery store, the reality is that that is now going to root itself in your pathway of decision making. And that means that the level of mistrust and the efforts required to build community and to build allegiances between healthcare organizations and communities is not something that is acute in nature, but it's very much chronic. So if you saw your mom or your grandmother go to the doctor and they were mistreated because of their race or their size or their sexuality, the likelihood is that the inhibition or for people to seek those same services across generations is going to be very much of a reality. And I think this is something we have to remind ourselves of, is not only do we have to be aware of our own biases, we have a responsibility as healthcare providers and workers to ensure that whatever biases and hesitations that people have, that they've created about the healthcare system, that we also have a part to play in helping to mitigate those. And this often in community work is related to people doing projects and not staying long-term or not building long-term sustainability to help overcome those things. So let's talk about a little bit further about the implicit and the unconscious things that happen in healthcare. So let's go back before we jump into our activity. Remember, the first time you see someone, you make a judgment. You create an impression. You categorize them in a way that centers your comfort. This allows you to write a narrative about them, which often creates an ability for you to determine if you feel safe, if you feel kindred, if you feel affinity with that person. It is not important to me for us to declare that these things are right or wrong. It is important to me that we can walk away from here today recognizing that for every categorization that we do, whether it has served us well in the past or not, there should be a small ability in each of us to say, while this has served me well in the past, I could be wrong this time. This may not be the narrative in its fullness. So we know from the studies that when you see something for 1/10 of a second, you make an assessment. And for every second after that, you begin to write a narrative that creates a self-centered truth for you about what you contacted. And this often happens with no verbal communication and no ability to clarify any of the assumptions. So let's talk about Carla. Carla was a woman in her late 20s. She went to the emergency room with her boyfriend. She had cut her hand on a glass bowl and shattered as it slipped to the ground and shattered. Her hand was cut from mid-palm to wrist and it was bleeding. Her boyfriend told the ED resident that quilting was very important to Carla and worried about damage to her fine motor control. Resident stated that he was confident it would heal well if we could just stitch it up quickly. As he prepared Carla's hand, a student volunteer walked by and recognized Carla, who in addition to being a quilter, was also an assistant professor at Yale. The ED doctor stopped in his tracks and said, "You're a professor at Yale." Within seconds, Carla was headed for the surgery department and the best hand surgeon in Connecticut was called in. After hours of surgery, Carla's hand was restored to pre-injury function. What happened here? What if the patient was Carmela or Carmelita? First thoughts. So we have less quality service. She could have just had her hand stitched by the resident. I mean, who's to say that it couldn't have been maybe just ace bandage and go home and put this on ice. Maybe they would have sent back to the waiting room and told to follow up with their primary care. We just don't know the answers to these questions, but there are some things that are very clear to us from this. And we don't know what Carla's race or sex is, but we're creating a story here that probably is spanning far beyond the information that we have been given here in the narrative. But there are some assumptions that I think we can make with some certainty. And let's look at this a bit more. This is an example of a hidden bias, and I'm not sure this was wrong. I mean, when I worked in a hospital and people that came in that were other nurses and so forth, there were things that we did lend ourselves to giving them special treatment. People that had had a birth with me before were probably given better treatment than people that hadn't, or things like that. And while our intention is not to do that, these things do creep in. So Carla's case is a very subtle case of healthcare discrimination. We have Carla the quilter, who was, that was the narrative that her boyfriend came in and told, and that became her story. This is a person who quilts. Then we had Carla the professor at Yale that created what we call an in-group bias. So Carla the quilter now became Carla the professor who happens to quilt. That's one of us. Have you seen this happen in any organization that you're in? Another question is, though you have seen this happen, do you think the motivation was to give someone better care than someone else? So I think most of us in our most perfect selves would like to believe that we would have treated every single patient the same, and that we would have elevated every patient up to a level of care of which we saw commensurate with what they presented with clinically. The reality is that when there are biases that check boxes, such as good looking, things you have in common with people that see the world as the same way as you, people that maybe even live or have lived or went to college or enjoy the same restaurants and the same music as you, those small seeds of bias can also be a part of that pathway, and they can affect how we treat people. It could have been that if Carla had come in and her cut was less significant than what it was, the in-group bias could have fast-tracked her ahead of other people that maybe had more life-threatening emergencies, all just simply because the person who was in control, the resident at that point, saw an ability to operationalize one of their biases, and it likely happened without them putting forth very much effort. Absolutely. And I think we all have to be careful of this. You know, if I go as a doula or as a support person with friends of mine who have asked me to be with them in labor, I certainly maybe go a bit above and beyond than if I would have to do this role with a stranger or someone I didn't have an affinity with. All right, we're going to keep moving for the sake of time. We're going to skip here because we already talked about that. And we're going to talk about first impressions a bit more. On the screen, I want you to type in your first impression. Let's get started. And remember, folks, it's supposed to be your first impression. So don't try to dress it up to say stuff like, well, you know, because we know that's not your first impression. Family. Family of today. Is that a man breastfeeding? Thank you. I really do see a family with 2 dads. Transgender on the bottom right. So for a lot of people, they said they saw families. And I don't think there's anything wrong with that. But without any information, we are using a series of shortcuts to create stories about people that may or may not be true. And one of those shortcuts that we're using is that families take pictures in certain ways. So if I look at the bottom right, this reminds me of family pictures that I have seen. I don't know if this is someone's, if this is a 3-generation picture. I don't know the answer to these things, but I made an assumption, and in our plight to be more diverse and be more inclusive, I just want to caution us all that in making assumptions that attempts to unmarginalize people, that we do not create stories that are not true without interacting with people. And I think that can happen here. This certainly could be a family that has twins. It could just be 2 people that work at a daycare that are kissing. However, the point is not to sort of determine these things. The point is to say, when you saw whatever is on the screen, you made an assumption, and it could be right and it could be wrong. And depending on whether or not it's right or wrong will have some impact on what you do next and how you interact with them. Now, I, as a lactation provider, have seen very few African-American same-sex male couples, transgender. I've seen very few, a little amount of this in my practice. I have seen large amounts of Caucasians or white people. But for many people interacting with minority populations, particularly African Americans, this may not be the norm. And whatever deeply seated beliefs you have about childbirth, about families, about mothering, about breastfeeding, those things certainly are going to have to be explored at an individual level as you continue to provide services. So thank you all for your participation there. And let's go here. So the question is what we see or what we think? So I think it's both, Venus. And I would venture further to say that it can be very difficult to separate those at times. I know sometimes people ask me what I see, and I've taken it 3 steps forward. Okay, overweight women relaxing and receiving care, fat, unhealthy, diabetes, unhealthy pregnancy. Um, I would take it a step further, and when looking at these pictures, centering that some of these are people that maybe got pregnant against healthcare providers' recommendations, and now that's a piece of the puzzle that goes into providing care in a complex and comprehensive world. What do we see here? So take what you see and then add this narrative to it. This is a couple that is interested in doing fertility to get pregnant. What's your impression? My first impression is, you know, are you sure having a baby is something that you want to do? Um, they probably aren't getting preconception care because providers aren't asking about their reproductive goals. Absolutely. I think that, you know, if these were patients that presented to my clinic saying that, you know, they were interested in preconception counseling, I would really need to utilize every skill that I have to mitigate every bias that would immediately pop into my mind. And in some cases, these people's preconception care would likely lend itself to a family planning option immediately. These are people that are seeking out services because they want to do breastfeeding and chest feeding across both parents. What are your impressions? These are people that are interested in doing the standard days method and the 2-day method, and these are their family photographs. They do not want to use hormonal birth control, and these are the photographs of which you can inform opinion about them. This is a mom who has 3 children who tells you that she anticipates wanting to have 3 to 4 more children in her reproductive life. This is a mom who is interested in understanding family planning options, recognizing that she would like to begin planning for a 3rd child in the next year. This photograph in the diversity world often recognizes that paternalism is as dangerous as this, where one individual sees all and makes all the decisions, and others are just supposed to blindly follow them. So as we wrap up, I want to recenter that we've done a lot of activities and discussed a lot of things today. And one of the major points that I really try to stress is that all of us have come to whatever space we have influence with our set of biases that take us down a pathway of categorizing individuals, applying stereotypes, and writing narratives that are largely based in our own comfort being centered. So what are we going to do about it? Well, first, we're going to come face to face with our biased selves and recognize that we are as much of the problem as we are a part of the solution. And this is a day-by-day thing. But one of the things I want us to talk about is using a mnemonic called pause. And pause is a way for us to check our reactions. Comes out of the book Everyday Bias, but it talks about acknowledging what you are, what you think, what you believe, and how you come to these things, and recognize that there may be other ways that people see the fine, good-looking man that has on eyeglasses and beautiful eyes. And these will all come to you after the presentation today. The 6 ways that I want us to all commit to practicing, myself included. The first is recognize that we all have bias. We need them. They're not going to go away because we need them to survive. The second thing is that we all need to develop our professional and personal plans to check these biases. Practicing constructive uncertainty says, even though every life experience has taught me that when I see an open chair, I can sit in it, that there may be a time where there's a chair that's open that no one is supposed to sit in. Maybe my constructive uncertainty has taught me that every time a patient does not progress on the labor curve, or a patient is not compliant with coming to the WIC office, that there are many other reasons of which they make those decisions that may be out of my sphere of knowledge or influence. We need to explore awkwardness and discomfort. I know there was a time in my life where I felt very strongly against intervention in birth, and was all on the natural train, to the point where possibly when things needed intervention, my pathways may not have been able to be interrupted. So there is some balance here. And the things that make us uncomfortable, the best way to mitigate them is to walk boldly towards them, recognizing that a space of discomfort in a season may emancipate you to a life of much more openness. Increase your engagement with people you consider to be other, and these are people that do not share the same worldviews as you. This is particularly true with the clients that we serve. For those of us that maybe have worked in homogenous populations, or people that have tended to work in places where all of the clients are the same, if we're not careful, we can thereby begin to create narratives that all people around the world or around the nation are exactly like this. I know, coming from the Indian Health Service, people often ask me to give testimony about what it was working there. And I often have to preface it with, you need to recognize there are over 500 different tribes, and this was my experience in North Dakota. This is not the experience or the reality of American Indians and Alaska Natives everywhere. Finally, the hardest part of mitigating our bias is to seek and be open to feedback. I don't know how many of you are prepared to go to your office mate or the person that you teach prepared childbirth or have baby cafes with and say, I invite you into my life to help me unveil things that I may not be aware of. I realistically don't believe most people are at that space, though there are some. So another tip that I'm going to give to help mitigate that is the project Implicit. In my workspace, senior leaders have accountability partners, and we all do one implicit association test once a month. And what we do is we share the results with another colleague. We take them all together in a room, and when the results come out, we pass our phones to the other person, and they see our results before we do. And this helps create accountability, and it creates maybe an easier invitation to allow people to help you mitigate some things that are coming out of this quasi objective assessment that comes out of Harvard. So I just encourage all healthcare providers and those working with communities to utilize an accountability approach and the Harvard Implicit Association test. There's over 13 or 14 of them, I would just encourage you to use that as a sounding board to start these conversations around accountability and really yielding the vulnerability of yourself. I will tell you, as an OB nurse and a person that's given his whole professional career to women's health and lactation, that there were some very revealing things on some of my implicit association assessments that had to do around career and family and gender, and how, despite all of my efforts to be a feminist and so forth, there were some inherent things that I was not aware of that the IAT has been able to help me with. And I suspect that's true of all of us. Lastly, blind spot. We use a lot of examples of blind spot in the course today or in the webinar. It is very difficult to talk about discrimination and bias and stereotypes within a polarized society, recognizing that there are other influences that we all have. Blind spot is a very non-controversial book that grounds everyone as a good person. So what we're doing and what I'm recommending in my work plans where I have sphere of influence is that people are using chapters out of this book to be conversation starters at staff meetings, at the beginning of webinars, hopefully taking the place of things like quote of the day and some of those things. This is available in audio and in actual print. And the Carla case comes out of here. Let me be clear. Every mother, regardless of race or background, deserves to have a healthy pregnancy and childbirth. I think we all agree with that. But there are things that are outside of our control and influence. And largely, these things manifest as our conscious and our unconscious biases. They are not going to go away tomorrow, but the ability to mitigate them gets better and better with time if we allow ourselves to be vulnerable and we develop the capacity for other people to interrupt in a non-confrontational way. I think we can all go on a pathway of making the unconscious very conscious. So finally, before we ask questions, my final question to you, my biased colleagues who want to do the right thing, that have a hard time interrupting stereotypes and motivations to categorize people, are we going to be a part of the solution or are we going to continue to be a part of the problem?